So HER2 positive breast cancer has been an area that's evolved over the last decade with the introduction of several new agents, and they apply to patients both in early stage and late stage setting as well as preoperatively. And one of the challenges we have, particularly in patients with metastatic disease, is to how optimally to use these drugs, extend the time that patients have, and really convey benefit to them. So one of the things that we base our decision making on, certainly in metastatic disease, is the results of clinical trials. And what the clinical trials have demonstrated is that we should be, for most patients, using pertuzumab and trastuzumab early, followed by TDM1. And then once we get past that point, then there are a variety of options, including drugs that are a little bit dated at this point, like lapatinib, as well as combinations of trastuzumab with other chemotherapy agents. And there are drugs on the horizon, including neratinib. With respect to early stage disease, one of the things that we now confront is how to integrate both pertuzumab and neratinib into the adjuvant setting. Data from the Affinity trial showed that there was probably a very modest incremental improvement in outcome when you combine pertuzumab with trastuzumab. Probably will not be for every single patient, but for those with high risk. And for those who have a very high risk, positive nodes, then we may consider neratinib afterwards. But we have to take into account the side effect profile of these drugs, and we're really talking about durations of therapy that go into years now. So it won't be for everybody. It'll be a selective decision.